Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Intracellular Therapies, Inc.
Hello, I'm Dr. Greg Mattingly, an associate clinical professor at the Washington University School of Medicine and president of the Midwest Research Group in St. Louis, Missouri. Welcome to this program titled Deconstructing the Diagnostic Journey, Identifying Bipolar Depression. Joining me today are two of my good friends, Dr. Manpreet Singh, professor of psychiatry and behavioral sciences at UC Davis, and Dr. Les Citrome, clinical professor of psychiatry and behavioral sciences at New York Medical College in Valhalla, New York. Welcome, everyone. Les, Manpreet, thank you for joining us. Let's begin with a question, if we could. So let's just start with the basics. Les, Manpreet, why do we still miss bipolar disorder?
You know, that's a great question. I've always asked myself this, but I make the same mistakes all the time. If I concentrate too much on the cross-sectional appearance of a patient, then I'll miss the diagnosis. And that's because the most common presentation for bipolar disorder is actually a major depressive episode, not a manic or hypomanic episode. So in an office practice, we see patients all the time who come to us for depression, right? If we just look at the cross-section, someone with unipolar depression or major depressive disorder and someone with bipolar depression will look identical in terms of the symptoms that they have.
That's right. Bipolar disorder is exactly as you described it, Les, an episodic disorder. And the problem with the episodes, too, is that they vary in length. Depressions tend to be longer, and by definition, manias tend to be shorter. And so it is very possible that you'll miss a mania if you don't ask about it. And it requires a longitudinal observation. So it's not just about a cross-section in time and having the right symptoms for the right period of time and with substantial functional impairment, but it's to look for it at every single clinical visit. So I always like to say for every patient that walks into your office with any mood symptoms, it's important to cover the full mood spectrum so that you don't miss a potential mania.
100% agree. I mean, depression's a set of symptoms, but it's not a diagnosis. It's what's causing that depression, I think, is the diagnosis. And Manpreet, I know you see kids as well as I do. Les, you primarily see adults. Let's go to some of the clues to help differentiate bipolar from major depression, because it can look different at different stages and different ages for our patients. So Les, let's pitch it out to you. What are some of the clues that help us to separate bipolar versus major depression?
Well, for me, what's very important is how many episodes they've had and how old they are. Because if they actually have multiple mood episodes and they're like in their 20s, something's up. It would be very unusual for someone with MDD to be in that position. But it's not at all unusual for someone with bipolar disorder, which usually begins in adolescence and early adulthood. If they have a family history of bipolarity or of suicide or of admissions to a hospital, then I take that very seriously as well. And there's this other thing, how they have their onset of depressive symptoms. If it's like a light switch was turned on or off, that's very distinctive of many people with bipolar disorder, where their episodes seem to come on all of a sudden, not gradual at all. And if they've had treatment before and it just didn't work, well, maybe it's because the treatment they received wasn't for their illness, which gets back to the point that depressive episodes last longer. I think they last longer because they're untreated or treated with something that doesn't work. The manic episodes are shorter because they're brought into treatment. Society tolerates mania very, very poorly, and patients get treated for their mania, usually as an inpatient because it interferes with everybody around them, and it's resolved. It's the depression. It falls under the radar. It gets misdiagnosed. They are depressed for longer. But if we look for these clues, how old they were when they first got ill, how many episodes they have had, and then you'll look for, maybe a history of hypomania or mania, by careful questioning, and I'm sure we'll get into that in more detail.
You know, what's interesting, Les, is that picking up on your point about mania being intolerable to society, sometimes functional hypomanias can be quite adaptive for a lot of patients. And I would say in the earlier stage of life, when you really don't have a lot of database of symptoms or episodes to draw from, it's often through a retrospectoscope older in older adults or young adults where you can actually find all sorts of episodes of hypomanias that were quite adaptive for a patient up until the point where it became maladaptive and functionally impairing or intolerable, as you said, to the individual, the family, and the society. I
You know,
think one of the things that I would say, really impacts a patient is exactly where in the lifespan they are presenting with these symptoms. So I always like to make sure that when I'm doing the longitudinal interview, that I'm looking forward and backwards, and to see where I can find clues about the symptoms leading up to that full manic episode. Kids, by definition, are diagnostic orphans because a lot of the symptoms that form a psychiatric disorder don't fully present or manifest in all their glory until later in pubertal development or at the onset of adulthood. You often see these very subthreshold presentations of a variety of different symptoms that look like co-occurring conditions. And unfortunately, that can lead to polypharmacy. So what we must do in that context is really understand what are the root causes of those symptoms, and can we find a common explanation?
yeah, I know we'll talk about hypomania, but hypomania, although may appear to be adaptive and may appear to lead to someone having an easier time doing some things, I think most people note someone with hypomania as being a bit off. It's just the person who's hypomanic
Mhm.
doesn't see it that way.
I would agree, Manpreet and Les. We certainly see these patients that, I stayed up late studying for a final, and now I don't need to sleep for a few days. And to them,
Mhm.
that feels good. But as you said, Les, to their husband, their wife, their parents, they're saying, wait a minute, there's something that's different here. Something has changed. We haven't mentioned family history. How do you use family history, genetic loading, a family pedigree? How does that help to shift your diagnosis one way or the other, or does it?
So, Les and Greg, I have been studying family history as a model system to better enrich sampling and understand the origins of bipolar disorder. And unfortunately, much to my frustration, most of the patients that I've followed who are children or offspring of parents with bipolar disorder don't go on to develop. But nevertheless, you do see somewhat of a familial clustering in families. It may not be Mendelian, so it doesn't quite follow the usual rules of generational transmission. But you do see oftentimes if you do a careful history, and I often like to in my diagnostic interviews ask patients about their family members, and you almost have to go a little bit around the issue. You can't just say anybody in the family with a diagnosis of bipolar disorder. Sometimes in other generations, people used to call that manic depression or other names. And so, you have a chance to ask these questions about actual symptoms, treatment histories. You might be a little bit more on solid ground to find those family members and pedigrees that do represent this sort of familial loading.
Manpreet, I know here in Missouri and Arkansas and Illinois in the middle of the country, a lot of times you see high genetic loading in a family with bipolar disorder, but it's not bipolar you see genetic loading of. It's just lots of mood stuff, right?
Right.
So I had an aunt who had postpartum depression. I had a cousin who had treatment-resistant depression. I had an uncle who got hospitalized. I had somebody in my family I think took lithium a long time ago. And that's the kind of loading I tend to see in my genetic family histories around here in the Midwest.
Yeah, that's exactly right. Les, did you have a similar experience in your region?
Yeah, so I was going to say most of the patients won't have a family history that would be remarkable and actually unhelpful. But for those that do and are able to tell me my aunt, uncle, grandparent was in a state hospital or was suicidal or had ECT, then I think that's very important information. It makes me think about, okay, this may not be plain vanilla MDD after all, and there may be something else going on. And it helps me explore in more detail. Okay, so exactly, have you ever had any periods of time where you didn't need to sleep as much? Not that you couldn't sleep, Not that you had insomnia, but that you were full of energy and didn't need to sleep. Look, if you've been married 5 times and you're 30 years old, something's up. You have a very troubled social history there. It may be due to bipolarity. It may be due to other things as well, but certainly
Sure.
something's up. Or if you have 10 different jobs in 3 years, it means two things. One, you're very good at getting jobs, but you just can't keep them.
Let's dive into the complex world of bipolar 1 versus bipolar 2 depression. So we know depression looks like depression. It's the same 9 symptoms we use, but the other things associated with it are very different. So how do we help to pull apart bipolar 1, bipolar 2 depression from unipolar depression? Manpreet, let me start with you this time. When you think about a bipolar 2 patient, what do you look for? Because they can fly underneath the radar and they get missed for longer periods of time, right?
Look, whenever a patient presents with any mood symptoms, I want to ask about depressive symptoms and mania symptoms. So I try actually to start with my low-hanging fruit. And if the family members and the patient indeed are comfortable with the interview, we've established a rapport, I will start with the patient on questions regarding mania and hypomania and rule that out first. At least know for a fact that there hasn't been a lifetime bipolar 1 manic episode. If I've done that, then I can go into the more complex areas, the subtle symptoms, the hypomanias that might define a bipolar 2. And if I start my interview with a depression, certainly that's a nice way to warm up if people are stigmatized around talking about mania more than they are about depression. However, what I find is people tend to stop after their interview on depression and never get to the mania symptoms. So if you can always remember that you've got to cover that continuum or that spectrum, and it's not enough to say, have you ever experienced a mania before? I tend to ask things like the index mood episode. Have you ever been cheerful, high, terrific, not your normal self, couldn't imagine life being better? And then I go into time criteria. And then I go into understanding whether I'm looking at a hypomanic episode or a manic episode. Once I've established that, the depressions are so common and very easy to establish rapport with in an interview, asking about feeling low, sad, unable to enjoy things that are normally fun for you, plus Siggy Cap symptoms. And then, of course, every day, 50% of the day or more for any of these index moods for at least 2 weeks for a major depressive episode and for at least a week for a manic episode or 4 or more days for a hypomanic episode.
Manpreet, I love that you start with positive life events. You start with, have you ever felt more than your usual self? Have you ever had increased energy? And then you dive into kind of the depths of when things go the other direction, right? Or when I got agitated, it felt uncomfortable. I couldn't control how high I was. I was irritable. I couldn't, but you start with positive. I do the same thing. So I start with strengths. I start with things you like to do. Now, when did those things get slightly out of control? When did they become dysphoric or uncomfortable, or you weren't able to control them the way you used to? So I love that approach. Les, what are your favorite rating scales? We're a big fan of measurement-based care. Do you have any favorite tools in the shed? What do you like to use?
Well, first off, everyone who steps into my office gets a PHQ-9, regardless of anything. That gives me a sense of any depressive symptoms that may be present, and it's transdiagnostic, actually, so it's helpful there. Besides that, I actually don't use very many others. I use the questions that are in the rating scales as part of the interview process. So I kind of like the mood disorder questionnaire as a reminder of what I need to ask in terms of past history of experience, some of the manic symptoms. The rapid mood screener also gives me some more information in a brief way about the episodic nature of depressive episodes, which is not covered in the MDQ. So I use them as fodder in my questions that I ask. I want to go back to the differential diagnosis. It's really hard when someone is younger. And it's hard because they don't have that life experience yet. When I see someone who's 50 years old and they are able to tell me their longitudinal history, and if they've ever been on lithium or valproate, well, then I have the answer, right? No one's putting anyone on lithium or valproate without a good reason, and I'm able to dig down a little deeper there. The other thing, too, is I can often have a collateral person involved here that is very knowledgeable about that person. So a husband, a wife, a parent, a sibling. And that gets me the information that the patient themselves doesn't have the insight to provide, or they may be so mired in their depressive episode that they really can't think through their past history as accurately as I need. Also, when you're younger, there's a situation where the first episode may be a depressive episode and they haven't had the opportunity yet to be manic or hypomanic. So depression in a young person is a red flag. It is unusual, and be on the lookout maybe for some associated symptoms and maybe some mixed features here. So we didn't talk about that yet. That's when you're depressed and you have some elements of mania or hypomania, which turns someone into a different kind of person diagnostically. But and you need to use these clues when someone is young and doesn't have the life experience yet of having the illness, and you don't just have that information yet.
Manpreet, how about for you? Any favorite rating scales or mental health vital statistics that you like to gather?
It's unfortunate that we don't have any validated screeners like the RMS or the MDQ for kids. We do have some screeners that have been developed by folks like Eric Youngstrom that have some validity and are being developed. We use those as screeners to help us bring the patient in to do that more in-depth diving. But in any given instance for a child, an adolescent, a screener can be really mostly used to get your foot in the door. You really must then follow up with a full diagnostic assessment to understand and rule out whether there's been evidence of a mania or hypomania. Because as we already described, manias and hypomanias tend to be a little bit nonspecific and indescript before adolescence.
Manpreet and Les, you both said something that's really important for the audience. Screeners are screeners. They're there to help kind of increase your diagnostic kind of curiosity, but they're not there to make the diagnosis, right? So it's almost a symptom loading to kind of see where we are, but they're not made to make the diagnosis. We have a couple of examples for our audience. So we have a PHQ-9. So the PHQ-9 is going to measure those 9 symptoms of depression. It's not making a diagnosis on what type of depression we have. So this could be 9 symptoms in bipolar 1 depression, 9 symptoms in bipolar 2 depression, 9 symptoms in unipolar depression. It's giving us a severity rating, kind of a symptom load. And I like the PHQ-9 because it's validated, it's easy to use, the patient fills it out. But item number 9 screens for suicidality for each and every patient. How about, Les, you already mentioned it, the MDQ. What are the strengths and weaknesses of the MDQ?
Well, the MDQ is a bit longer than I would like, but it's pretty easy. You either have it or you don't in terms of the checklist of a history of manic symptoms. However, I find it easier for me to ask some of the key questions first. If someone is kind of reluctant to, really communicate with me, then they may respond to a rating scale better. Oddly enough, people fill out forms sometimes better than they answer questions. So I find that helpful to have that in my back pocket. It helps me be grounded in terms of thinking about bipolarity. That's how I use it. The rapid mood scale or screen is complementary. It does not replace the MDQ, although I guess you can use it instead, but it is very brief. But it gets into the cyclical nature of depression, which the MDQ does not. So there's one thing about the PHQ-9, though, that I think should be mentioned. It could be called the PHQ-10, actually, because there's 10 questions. That 10th question is really important, and that's the impact the symptoms have on a person's functioning, and that's critical. Patients like it because then they're able to relate, their symptoms to actually how they're doing day by day. And about number 9, the screening for suicide, I never take it at face value, because if someone scores 2s and 3s and then nothing on number 9, I ask about it. And very often I'm told, well, I didn't want to really write that down because they didn't know how that would be interpreted, and they're fearful of being locked up and so on. And I have to say that, lots of people who are depressed think morbid thoughts, and it's not at all unusual. We need to talk about how these thoughts are for you and whether or not you think that you're in danger or not. That's what we really need to know.
I agree. We used to use the Beck less. So years ago, Beck was our initial screening instrument because it had more of those kind of than, just ruminative thoughts about, how tough life can be. We use the MDQ. So the MDQ
Mhm.
is one of our 5 mental health vital statistics. We do the PHQ-9, the MDQ, the GAD-7, the ADHD-RS, and a 9-item PTSD trauma screener with every patient. And we now call it our mental health vital statistics. We get them from each and every new patient.
Nice.
Manpreet, how about the RMS? Any thoughts about it? It has some pros and cons. I don't use it, but it does talk about treatment history and age of onset, right?
Yes, it does highlight those very important factors that I think raise your index of suspicion, especially in early age of onset, but it's only validated down to 18. I like it because it's short for down to 18. And like other instruments we've already discussed, all of these are meant to provide corroborating information. We often get young adults, 18 and above, who don't actually want to engage collateral information. They don't want their family members involved. They're feeling perhaps shame about their symptoms and have had other stigmatizing issues or consequences or complications as a result of their psychiatric symptoms when they're presenting to us. So these tools can be extremely helpful for corroboration of the symptoms that the patients report. And if you can get them in different ways, I look for consistencies and inconsistencies in my diagnostic interview, and then what's written on paper and what's discussed or reported orally. And these inconsistencies and consistencies can lead to further questioning or obviate the need potentially for getting collateral information. If things just don't jive with each other, then that's going to be a good reason for us to make sure that we try to get at the answer and the truth for a patient at any given cross-sectional time with rating scales or measurement-based care. I don't use rating scales necessarily to monitor symptoms or treatment responses, but I can often find them very useful to at least give me an operational scaffold for symptom monitoring and treatment response.
Let's talk briefly about treatments. So when we talk about treatments, I tend to think about less, historically when I first started research, it was bipolar mania. How do we help somebody who's manic? We get them to sleep, bipolar manic treatments. Then it became bipolar relapse prevention treatments. So maintenance relapse prevention. Only more recently has the field truly developed bipolar depression treatments. So treatments that are approved for bipolar 1 depression, bipolar 2 depression. I think that those have been newer innovations in the field. So how do we pick them apart? There's a lot of options out there. We have mood stabilizers, we have atypicals. Probably one of the first things to talk about is, are any of the antidepressants approved for bipolar depression?
No, they are not. No, none of the traditional antidepressants, SSRIs, SNRIs, have ever been approved for bipolar depression, and they don't work in the vast majority of people with bipolar depression. Now, there's a small minority of people that seem to derive some benefit, and it's very controversial. You're mostly going to get it wrong if you use a typical antidepressant in someone with bipolar depression. But let me take a step backwards. Now, you laid it out how these treatments for bipolar disorder were first organized. They're still organized in that way. So the FDA has approved drugs for bipolar disorder based on the phase of illness, whether it's mania, depression, or maintenance. This is not the case for other disorders such as major depressive disorder or for schizophrenia, where drugs are approved for the condition in its entirety.
Right.
This is different. And it does mean that some of the medicines that we use for bipolar mania do not work for bipolar depression any other way around. And not all the medicines that we use for mania or depression are actually approved for maintenance. And there's one drug that's approved for maintenance and nothing else. So it really is kind of an odd situation for us, and we need to keep it straight. We have many choices for bipolar mania treatment. We have quite a few for bipolar maintenance. We only have 5 for bipolar depression.
Less well said. And I think the biggest mistake I see my medical students or my nursing students make is they think because they're approved for one phase, they work for all the phases. And I think we all know, lamotrigine broke my heart. I was in those trials. I was sure it was going to work for everything. And then it just took too long. It just didn't work consistently enough to get approved for the other indications beyond relapse prevention. So let's take a look at, okay, if somebody has a lot of mixed symptoms, you brought this forward earlier, Les. This is a place where it's very easy to fall into the antidepressant trap, right? I'm depressed, but I'm wired and tired. I'm depressed, but I don't seem to need to sleep. I'm depressed, but I'm a little bit dysphoric, but a little bit euphoric at the same time. Antidepressants in that group of patients, we use them, but they haven't been shown to work very well, right?
Not only that, they don't work very well and they can actually make things worse. So that's our biggest fear, right? We give a treatment and they appear worse. Well, that gives us an opportunity to revisit the diagnosis, and maybe we got it wrong.
And
And
I know,
that
man,
regulation is really important, that figuring out where it makes sense for us to introduce antidepressants. Some people would argue it's not an if, but when, makes it difficult for us to get antidepressants out of our minds. But in the presence of mania or hypomania, the the general rule that does seem to work pretty consistently is mood stabilize first, address the hypomania and mania, and then you can look to see if there are residual symptoms of depression that cannot adequately be addressed by optimizing the primary agent. I always like to use the KISS principle and keep things simple as much as possible, because patients don't need drug interactions or complicated drug regimens. And in the context of other corroborating evidence or risk factors like family history, one needs to really think carefully about the indication for antidepressants, and whether they're going to be more harmful than helpful.
yeah. I'll just leave the audience with 2 points on this and then we'll move on. Joe Biederman's study years ago looked at if you have depression with mixed symptoms, the more mixed symptoms you are and the earlier you are, the higher the chance eventually you're going to convert to bipolar disorder. The resource we have for the audience, I believe, is the Bridge study, which took a look at if you have mixed symptoms, what's the chance you're going to have antidepressant misadventures? And you were 3 times more likely to have
Right.
antidepressant misadventures if you were having mixed symptoms when you tried that antidepressant. Les, walk us through the treatments that are approved for bipolar depression, both bipolar 1, bipolar 2. It's a pretty small list. I think it's the list of 5, right?
That's correct. It's a list of 5. There's a variety of choices here. Each of them are different in terms of which receptors they hit and their side effect profile. They're all very similar in terms of how well they work. Some are
Mm-hmm.
approved as monotherapy only. Some are also approved as adjunctive use to lithium or valproate. Some are approved for children and adolescents. But not all of them. Does that prevent us from using the ones that are not? No, it does not, but it would be an off-label use at present. In terms of bipolar type 2, this gets a little tricky because I think by and large they all work, but only 2 companies actually went through the effort of including bipolar type 2 patients in their clinical trial development program. So we only have 2 of the agents that are specifically approved for also use in bipolar type 2, but they're all very different in terms of how they're tolerated. And, I really like to talk about tolerability in terms of number needed to harm. I can't help myself. And I know that would be the next question you would ask me, Greg.
Before
Les,
you do, though, Les, could I say something briefly about the pediatric indications? Because there is
Yes.
one exception to the rule about where I would not potentially prescribe given the preponderance of the data. So olanzapine, fluoxetine, and lorazepam are FDA approved for bipolar 1 depression in kids down to age 10. However, quetiapine, even after systematic meta-analyses have been conducted, does not seem to work effectively for youth. Interesting. This is different from the adult literature that quetiapine has time and time again failed in randomized controlled trials for bipolar depression. So we tend not to use it as often for first line treatment of bipolar depression in youth. You've got other medications that are actually currently being tested, including lumateperone and cariprazine, that are undergoing pediatric extension trials. So hopefully we'll know more about those 2 and how they work in the context of pediatric bipolar depression soon.
having been a part of the lorazepam trials, the cariprazine trials, and the upcoming lumateperone trials, which are underway, I think what Manfred, you and I, when we take care of kids, they are at such a risk of metabolic issues, weight gain, that finding tools that are clean for metabolics are especially important in those teenage youths that are at very increased risk for that. Let's dive into your world. You are the master of number needed to treat, number needed to harm. So these are the 5 that approve, but how do we pick them apart when it comes to side effect profile? Walk us through it.
Well, the way I look at it, there's basically 3 important buckets: weight gain, movement disorders, in particular akathisia, and sedation or somnolence. But we can expand upon that and also look at nausea, extrapyramidal symptoms in general, so movement disorders in general, as well as discontinuation rates due to adverse events as observed in the clinical trials. We can calculate number needed to harm, which actually answers the question how many people needed to be randomized to the medicine in question versus placebo before expecting one additional person to have that adverse outcome we would like to avoid. The smaller the number, the more worried we are. We like large numbers for number needed to harm, which would tell us that we seldomly encounter these problems. Basically, a number needed to harm value less than 10 represents something that will happen commonly in day-to-day clinical practice, and there's no avoiding it. So if we look at olanzapine fluoxetine combination versus placebo, at the outcome of weight gain of at least 7%, the number needed to harm is 6, which means for every 6 people who are randomized to OFC versus placebo, you would expect one additional person to gain that amount of weight in those short-term studies. That's a problem, and that means it happens about as often as response or remission. Quetiapine has a number needed to harm of 3 for somnolence. 3, which means you're actually twice as likely to encounter somnolence or sedation than response or remission. So that's a problem with OFC and quetiapine in my mind. The other 3 choices, cariprazine, lumateperone, and lurasidone, have mainly number needed to harm values greater or equal to 20, which represents a lower risk. And for some of the doses, a number needed to harm between 10 to 19, which I can live with. So I've constructed these heat maps where green means go, yellow means exercise some caution, and red means I'm not so sure about this. And the sea of green is with cariprazine, lumateperone, and lurasidone. And with cariprazine and lurasidone, it's at the lower dose range. So with cariprazine, 1.5 milligrams a day, and lurasidone, 20 to 60. They're basically green. Green means go in terms of tolerability. Now, if something doesn't work for that individual person, I will have to switch, and I do that. And I'm just thankful that these medicines are sufficiently different pharmacodynamically from each other.
And Les, I tend to think of the red list as the safety nets. That's my safety nets. I want to start in the green to go. I love your heat map. Green to go to start with, move to your safety net if you have to go to your safety net, but you know you have pretty predictable side effect burden there. If we were going to pick apart weight gain by itself, do you think are the top 3, or is it one of them any better than the other when it comes to weight gain?
So lumateperone has absolutely no difference in the amount of weight that was gained. So I was very intrigued by that. The rate of people who got their weight increased by at least 7% was 0. But never say never in clinical practice. And I've had patients who gain weight on stuff they weren't supposed to gain weight on, and who don't gain weight on stuff they're supposed to gain weight on. But if I just look at the data, lumateperone has no difference in the weight gain between drug and placebo, and cariprazine looks very good there as well. Lurasidone also looks about equally as good. So all 3 of those choices I'm comfortable with in terms of mitigating against weight gain.
I would agree. Manpreet, let me ask you our final question here. We'll start with you. When we think about patients based on their age, their gender, and some of the social determinants of health, mental health doesn't live in a vacuum. It depends on stress and adversity and things around you and your cultural background. How do we put those into kind of a holistic treatment approach?
Right. And I think this is where the diagnostic interview principles of starting with what's comfortable and open-ended, and really giving the patient an opportunity to talk about things that they care about, that brought them into treatment, that they're prioritizing their functional strengths, if you will, and then move to areas of concern can be very helpful. I think that there are some key questions that we need to have in our back pocket always. It's always important to know that even if a patient is coming in a low mood, you must ask about the times when things were better or potentially even maladaptively high or euphoric or cheerful and not their normal selves. So any departures from baseline are real opportunities for us to learn more about the patient once you've established a rapport. But the context of cultural sensitivity and histories of trauma tend to almost negate our assessment of a mood database. Some people just say, oh, this is all trauma. Well, what makes us think that mood disorders don't also involve trauma or put patients at risk for trauma or potential abuse or neglect or other factors? It makes it really important, I think, for us not to just end the conversation with the things that have been stressful to our patient, but really make sure we understand the impact of those stressors in terms of their symptom presentations and how they're coping with them. So I find it's really important when we are doing a culturally sensitive and patient centered interview to ensure that we ask the questions that help us get to a diagnosis ultimately. Because it's not enough for us to know the context of those symptoms. We have to absolutely confirm whether or not those symptoms are not only present, but also their functional impact.
Manpreet, I agree. I mean, if you're a young person who's trying to be an athlete, if you're a mom who's trying to take care of your kid, if you're a person of faith who you feel like depression has robbed you of your connection with your faith, those are all very important culturally sensitive aspects that can have, both damage but also be very sustaining when we get them on the right track for our patients. Les, anything else you'd like to add about kind of these social determinants of health and how when you take care of a diverse, background of patients, how do you make sure you have patient-centric care for them?
So it's important to know the language that they use to describe psychiatric symptoms. And there are some cultures which don't have a word really that they use every day for feeling blue or sad or depressed, but it's more that they feel tired or don't have energy. And it reminds me of the French expression, je suis fatigué, which means I am tired, which is a code word for I am depressed. And in in my practice, I've treated lots of native French-speaking people, and so I got to be very in tune with that. But there's other situations where different words, different ways of expressing things, and also the stigma associated with having a
Mhm.
mental illness. Uh, we need to consider that when providing our care.
Manpreet, Les, let me thank both of you for joining me. Unfortunately, I think we're running out of time. We could do this forever. Always enjoy meeting with both of you, talking about these important topics. Um, Let me thank everyone, and please join us again for another episode of discussing the differences in bipolar disorder, depression, and mental health.